Okay, welcome everybody to this webinar from the Center for Vaccine Preventable Diseases at the University of Toronto. Today's webinar is about attitudes to vaccination, misinformation, and vaccine uptake during COVID-19. And I'm really pleased to introduce our three panelists that we have with us today. They are Drs. Shannon MacDonald, Dr. Devon Greyson, and Dr. Holly Wideman. So I'm just going to do some, mention some housekeeping items first. Or actually, I'm going to start with the Indigenous land acknowledgement. So first of all, we'd like to acknowledge the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous peoples on which the Dalla School of Public Health now stands. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. We would also like to pay our respects to all our ancestors and to our present elders. So I just realized I forgot to introduce myself. My name is Jeff Kwong. I'm the Interim Director of the Center for Vaccine Preventable Diseases. I'll be the moderator for today. So we would try to address as many questions as possible. There's two ways for you to ask questions. So you can either direct questions to the panelists using the Q&A function of this webinar, and we will try our best to get to as many of them as possible. Alternatively, you may send us an email after the webinar at the email address cvpd.dlsph@utoronto.ca. That's going to be put in the chat function so that you can use it to email us, and we will try our best to answer your questions. So without further ado, I'd like to introduce our three panelists. So first off, we have Dr. Shannon MacDonald. Dr. MacDonald is an assistant professor in the Faculty of Nursing and adjunct in the School of Public Health at the University of Alberta. Dr. MacDonald's research focuses on developing evidence to support immunization best practice, programs, and policy, and to promote informed decision-making by parents. Next, we have Dr. Devon Greyson. Dr. Greyson is an assistant professor in the Department of Communication at University of Massachusetts in Amherst. Dr. Greyson's research focuses on the ways people and health systems negotiate contested knowledge in everyday life and how information could be used more effectively to promote the health of populations. And last but not least, we have Dr. Holly Wideman. Dr. Wideman is an associate professor in the Department of Family and Emergency Medicine at Université Laval and holds a Canada Research Chair in Human-Centered Digital Health. Dr. Wideman is also a scientist at VTAM and the CHU de Quebec Université Laval in Quebec City, and an affiliate investigator at the Ottawa Hospital Research Institute in Ottawa. Dr. Wideman's research focuses on the design and evaluation of digital media and health decision-making. She specializes in human-computer interaction in health education, risk communication, and decision-making, including design methods to support inclusive user and patient-centeredness. So the format of this webinar is that we'll have each of our panelists give their remarks. We'll have some questions for each of them, and then that are pre-prepared, and then we'll also have some open Q&A from the audience. So we'll start with Shannon. Why don't you get us started, Shannon?
Sure. All right, sorry, let me just get set up here. Okay, so we've all seen the various public opinion polls that are out there about who is and who isn't intending to get vaccinated with the COVID-19 vaccines that are in development. And public health officials federally and provincially and territorially are busy trying to figure out ways to ensure that uptake of the vaccine is going to be as high as it can be amongst those that are eligible to receive it. And certainly there's a lot of talk in the media and as well as public discourse around vaccine hesitancy, that term we keep hearing, and vaccine hesitancy regarding future COVID vaccines. But I think it's really important for us to remember in the discussion today and in moving forward that vaccine hesitancy is only one determinant of whether someone is going to get vaccinated. So I'd like us to look at the definition of vaccine hesitancy so we can be clear on what it is and what it is not. Next slide, please. Thank you. So as you see here, vaccine hesitancy refers to reluctance to receive recommended vaccination because of concerns and doubts about vaccines that may or may not lead to delayed vaccination or refusal of one, many, or all vaccines. So as you see in this figure, vaccine attitudes exist on a continuum, ranging from complete refusal to total acceptance. And vaccine hesitant individuals are this heterogeneous group in the middle of the continuum. They may refuse some vaccines but agree to others. They may delay vaccines, or they might accept vaccines but still be unsure about whether they've made the right decision. So as you see, someone really could be fully vaccinated but still be vaccine hesitant. So the important distinction I'd like us to pay attention to here is that vaccine hesitancy is an attitude, not a behavior. And ultimately, it's the behavior of uptake of the vaccine that provides protection from the disease. So vaccine hesitancy, or in fact its counterpart, which is vaccine confidence, is only part of what we need to think about when we're looking at whether or not vaccine uptake is going to occur. Next slide, please. So there's lots of different models we have out there about ways of thinking about the influences of vaccine uptake. I'm sharing with you one here, which is one of the more holistic models. It's been designed by Cornelia Besch and her team, and it's a model of the psychological antecedents of vaccination. The model is commonly referred to as the 5 C's. And the 5 C's, as you see depicted here, include confidence, which is trust in the effectiveness and safety of vaccines, as well as the system that delivers them. So trust in healthcare workers, government, and public health officials. It also includes complacency, which refers to the perception that risks of diseases are low, or that a vaccination is not necessary. The third characteristic is collective responsibility. So what this is, it refers to the willingness someone has to protect others by getting vaccinated and contributing to herd immunity. And the flip side to this, of course, is the willingness to be protected by herd immunity achieved by others who get vaccinated, while refusing vaccination for oneself. Sometimes we refer to this as free riding. The fourth characteristic, calculation, is the extent to which individuals engage in extensive information search, weighing benefits and risks. And this, of course, could drive somebody to vaccinate as well as to not vaccinate. And I'm sure we'll hear more about this in Devon's talk. And the fifth one, which I'd like to spend a bit more time talking about, is that of constraints. So constraints refers to structural as well as psychological barriers to vaccination. Things like physical availability, affordability, geographical accessibility, as well as the perceived self-control and ability to understand immunization services, which may be impacted by things like language and health literacy. And in the next two speakers to come, we'll hear more about these various determinants of vaccination and how they can be influenced. I'd like to mention a little bit more about constraints, just to set the framework for that. So there's a tendency to think about vaccine uptake sort of as this supply and demand formula. So if people are convinced they want to get the vaccine, we have demand. And if the health system supplies the vaccine, we have supply, and magically everybody will get vaccinated. We tend to think of this in a really linear way, that constraints are something that occur after a person has made the decision that they want to vaccinate. But really, we have to be mindful that there's much more interplay than that. People are constantly weighing the various competing demands in their lives. So constraints are not something they consider after they've decided they want a vaccine. Instead, constraints enter into decision-making at every step. So a couple of examples just to explain that. So let's say we make a vaccine hard to access by not publicly funding it. that is typically leads to a perception by the public that the vaccine is not important. So it actually influences complacency about the disease. And we've certainly seen this with privately funded vaccines where uptake is quite low. Another example would be if someone has lost trust in the health system or their provider because they've faced access challenges in the past, for instance, discrimination when they access services. When the trust in the system is shaken, then trust in the providers is shaken as well, and trust in vaccines is shaken. So there's that interplay again between access and now confidence. So we also need to be really mindful that there's inequity in the constraints that people face and how the same constraint can impact on someone really differently due to the intersection of other factors they're dealing with. So an example would be if we end up providing the COVID vaccine by appointment only, which has been discussed because we want to avoid disease transmission in a lineup or a waiting room. We may think we're providing the vaccine to everyone equitably because we're offering evening and weekend appointments. But in fact, for someone who has unpredictable access to transportation or childcare, or has lots of other competing demands in their lives, the appointment system itself may be an insurmountable barrier to access. So just in conclusion, I'd like us to remember that as we learn more about misinformation, disinformation, and trust from Devon, and individual decision-making interventions from Holly, I want us to keep in mind that it's not all about influencing people's knowledge, attitudes, and beliefs. The healthcare system and those of us that work in it have a role to play in ensuring that constraints don't influence someone to not get vaccinated and that access to the vaccine is provided in an equitable manner. And then I will pass it along to my colleagues.
Great, thanks so much, Shannon. Next we have Devon.
Thanks, Jeff. I'm pleased to be here in such good company today and to be speaking to you from the ancestral and unceded homelands of the Pecumtuck and Nonotuck peoples. Pausing for my slides to come up here. Within health communication, my area of specialty is public health information behavior, which is a fancy way of saying I study what people do with health information and when this matters for population health. The most interesting and challenging topics are those such as vaccination, in which the health information ecosystem has become messy and polluted through a combination of deliberate dumping of falsehoods and innocent misconceptions. And that's what I'm going to dig into a bit with you today, specifically as pertains to COVID and vaccination. Next slide, please. I'd like to start out with a couple definitions. Misinformation is not the same as disinformation, and this matters. Misinformation can be defined as untrue or inaccurate information that is often transmitted innocently or with good intent. Disinformation, on the other hand, is false information shared purposefully, often with nefarious intent, such as personal financial gain, political manipulation, or to sow dissent within a group or population. Disinformation and misinformation are related. In fact, some misinformation originates as disinformation, but disinformation always has a motive behind the deception. In our networked era, in which sharing information is easier than verifying its accuracy, we unfortunately see a great deal of both of these. And in the context of the COVID-19 pandemic, as it's unfolded thus far, some examples have been, early on there were instructions for how to quarantine your groceries. These weren't wholly accurate, and many well-intentioned people shared this misinformation. And it probably didn't hurt people and was probably done with good motives most of the time. However, throughout there have also been many claims about fake cures or preventions for the novel coronavirus that have ranged from relatively innocuous instructions to like drink or gargle water to recommendations to ingest potentially dangerous substances. And in some cases, such disinformation was started by people with financial motivations to create demand for certain substances, such as dietary supplements they sell. Additionally, we've seen the spread of unfounded rumors and conspiracies that are increasingly intersecting with existing biases and conspiracies. And the effect has been to pollute the information environment around the virus, the pandemic, and potential vaccines, which causes confusion, reduces public trust in evidence-based instruction, such as wearing masks and engaging in physical distancing, and increases divisions in populations, such as the rise we've seen in anti-Asian racism. This year, disinformation campaigns around COVID-19 have really frequently converged with existing conspiracy and disinformation networks, such as those around the QAnon phenomenon. And this is something we've seen happen with anti-vaccine disinformation over the past few years. When I started studying vaccine information in 2015, one thing we could say we had going for us in vaccine communication was that unlike some other polarizing issues such as climate change, vaccine hesitancy, which of course is having doubts or concerns about vaccination, as Shannon mentioned, did not at the time have a political affiliation beyond perhaps libertarian values that could be found on both the political left and right. We found individuals and communities with this vaccine hesitancy across the political spectrum without substantial clusters several years ago. However, there's been a fairly rapid shift in this, with vaccine hesitancy increasingly clustering on the right, led by some prominent anti-vaccine activists. And this has happened to be the case in several Western countries, including, but not limited to, Canada. In addition to being associated increasingly with the political right wing, anti-vaccine views, which have long involved elements of conspiracy theories, have become more intertwined with other conspiracy theories, which have then spread through networks of vaccine hesitancy and anti-vaccine activism. In some cases, we've even seen pro-vaccine efforts, such as the legislative measures to eliminate non-medical exemptions to vaccine mandates in California, feed organized resistance networks that created sturdy infrastructure for spreading other conspiracy theories, including this year, disinformation about COVID-19. Several anti-vaccine movement leaders have seized this opportunity to promote disinformation about the novel coronavirus and build their followings, even among those previously unconcerned about vaccines. Next slide, please. So I often get asked, what can we as regular people do about this polluted health communication environment, and especially about COVID-19 vaccines? I often hear people ask, what do I do when someone in my community, perhaps a friend, family member, or acquaintance, is perpetuating misinformation? So first off, remember the difference between disinformation and misinformation. Someone spreading disinformation on purpose has an agenda, and you're unlikely to convince them to change their tune. But research indicates that someone who is well-intentioned but sharing misinformation is often worth engaging with. We often feel that it's useless to try to correct other people, but research is showing that correction can make a difference, especially if you're correcting someone that you know. Unfortunately, there's no one-size-fits-all script to correct false information, but there are a few principles that usually apply. And 5 of them I'm going to highlight here. The first is to use language appropriate to the relationship that you have. So don't be sarcastic unless you are usually snarky with that person, in which case, go ahead. Secondly, you want to build on your common ground. For example, I found it hard to keep up with all the COVID news too, Uncle Joe, but this one is actually false. Or, yeah, I know you're really worried about the well-being of our children, and I am too. So I think you'd want the most updated science on this topic. The third is, and this one's tricky, don't repeat the false stuff because it reinforces the misinformation, even if you're trying to debunk it. We know that advertising works, and no publicity is bad publicity. Repeating the false claim can reinforce it accidentally. So it can take some practice to not do that, correcting something without repeating it. You might try referring to the larger topic and not the inaccurate details. For example, while that meme you shared isn't accurate, it turns out there are some other things we can do to protect ourselves when we come home from grocery shopping, such as washing our hands for at least 20 seconds with soap. Apparently the coronavirus is really vulnerable to soap. A fourth thing we can do is refer to a reliable source to back yourself up. So for many people, we could refer to Health Canada or the World Health Organization. However, sometimes you are talking with someone who doesn't trust the usual trustworthy sources, in which case that may not work. If you can refer to a source they trust, do that. And finally, and this is critical, do your best not to let it get political. Misinformation, we don't want this to be, it's not about Justin Trudeau or Bill Gates or Trump or the Clintons, and it's not going to help correct information to let the conversation go there. Next slide, please. Now, how can we counter misinformation on a community or policy level? Well, the good news is that several policymakers in Canada are already doing some of the most recommended things to build trust in science and counter misinformation in communities, such as providing regular and consistent updates and delivering the messaging in calm, confident, and compassionate manner. But there is more that can be done. Perhaps the most important move is for politicians to leave the health and science messaging to medical and scientific experts. The public has far more trust in doctors and in scientists than in politicians. So it is doctors and scientists who should be delivering important messages and updates about the pandemic, including about vaccination. This also allows political leaders to be good role models for the behavior of looking to medical experts for medical answers. In addition, transparency is key. This applies to policy decisions. Make the reasoning behind a decision, such as a mask requirement, clear and readily available at multiple levels of detail. But it also applies to things like the data from clinical trials for vaccines and therapeutics. Requiring that these data be available for public scrutiny is important for building trust in eventual vaccines. In addition, it's critically important for public health and medical institutions to build and strengthen relationships with communities that have been alienated from these institutions. This means reaching out respectfully to invite members of communities who don't trust us to meet us for conversations and to tell us about their needs and priorities. We need to help them meet their own goals and then ask for their help and advice in conveying messages to their communities. On a community and policy level, building confidence in decisions such as a new vaccine program really comes down to trust. Behaving in a trustworthy manner and employing trusted messengers for specific communities are incredibly important for the credibility of information and for health programs such as vaccination. Thanks.
Thanks so much, Devon. That was great. Next, we have Holly. And do you have slides for Holly?
I'm just waiting for my slides to show up. Here we go. All right, thanks so much. And like my colleagues, I'm really honored to be here with such a great group. And I think this is a really interesting and important topic. Next slide, please. So just a quick heads up that sometimes I have stuff that buzzes and beeps, and that's for medical reasons and not because I'm checking Twitter while giving a talk. Next slide, please. So the background that I bring to this topic and all the topics that, that I research is from human factors engineering combined with social science, specifically decision sciences. And I think this is an important point that I always like to make because from my perspective, we tend to do better when we design for the way people are, not the way we wish they were, or try to adapt systems to people rather than expecting people to adapt to systems. And I think this speaks to what both of the previous speakers discussed, and especially Shannon's points about ensuring that the system is set up to facilitate people behaving in the way we would like them to behave for best public health. So I do this, I take this approach in a lot of different contexts, and one of the contexts in which I work, but not the only one, is has to do with public health topics like vaccines and some emerging work to do with COVID-19 public health messaging. Next slide, please. So one of the things that, that I work in with respect to vaccines particularly is in what is called decision support, patient decision support, or patient decision aids. So if you've never seen a patient decision aid, this is an example. This is made by the Mayo Clinic, and this is a patient decision aid about whether or not to take statins. And so this is a pretty typical kind of topic for a patient decision aid. And this is the kind of topic in which these tools would generally be used. And patient decision aids are tools that are intended to complement, not to replace, a conversation with a trusted health professional. And they can take many forms. They used to be pamphlets. At some point, they became pamphlets accompanied by audio tapes. Nowadays, they're mostly available as websites that can be used that can be used outside of a clinic visit, inside a clinic visit. Sometimes there are things that, printouts that come into the clinic and that sort of thing. Different people do this in different ways. But the point being is that often these tools are used for what we call preference-sensitive decisions. And these are decisions in which, medically speaking, both options are fine. Or you have, you have 4 options and they're all about the same in terms of their medical outcomes. So what really matters is how the person feels, how what matters to them aligns or doesn't align with the different options that are available to them. Vaccines have always been a slightly controversial decision to bring into the patient decision aid space. And similarly, the idea of engaging in shared decision making around vaccines is also controversial because it brings this idea that that it's okay to decide to make decisions that might not be aligned with what public health would prefer that people do, or would suggest is the optimal decision for people to make. And so this is kind of an interesting ethical space in which to work. And I think what I will do is just sort of lay my bias on the table, which is that I am really interested in building tools that help people in that middle section, in the part that Shannon showed there. So these types of approaches are not intended to support decision making among people who are hardline in one direction. They are intended to support people who have questions. And I think that there's a lot of value in essentially aiming to meet people where they are. And answer questions that they might have. Next slide, please. So what we do for this, we build lots of different tools, and this is just to show you, to give you a visual of our lab, which we are currently not allowed to be in. But when we do work in the lab, this is what it looks like. Next slide. These are members of my team. And this is what it looks like when we have a person participating in a study. So this is how we develop these kinds of tools. And the reason we're interested in all this psychophysiological equipment is that it is really important when you're looking to support decision-making to attend to a person's emotions as well as their attention. So often when we talk about how people make decisions, there's sort of this implication that humans are rational. Humans are not entirely rational. That isn't a reasonable expectation to have. We make decisions based on what feels right to us. And this is not a bad thing. This is, I don't think it's a bad thing. It's just part of how humans are. And so we should develop tools and supports for people that take that into account. So that's part of what we do here. Next slide, please. So one of the things that is happening right now in my group, this is my PhD student, Hina Hakim, who's just finishing up her PhD, and she has developed a visualization of how community immunity or herd immunity works. So these are some slides, and what you see there is you see in the middle of the slide, you see heat maps, which are showing where people's eyes are looking as they are interacting with this visualization. Next slide, please. So what happens in this visualization is, first of all, people make an avatar of themselves, and then they make two avatars of people around them who might be more vulnerable for whatever reason. So this is Hina making it, and she's making making avatars for actual people in and around our group. And then there's the individual themselves, two vulnerable people, and then 6 other people in their entourage. So people that they might come in contact with on a regular basis. And these avatars are then put into a narrated animation. And the reason we do this way is that there is some evidence that people identify with avatars, and what our goal is with the avatars. Next slide, please. I think I've just started over. So these get dropped into a visualization with a narration in which the concept of herd immunity or community immunity is explained. And the idea of using avatars is to make it personal. And the idea of using an animated narration is to make it accessible, because these concepts, so as you saw when I showed the Mayo Clinic slide, the Mayo Clinic slide is showing risks. So here are the risks out of 100 if you take a statin and if you don't take a statin. And those are individual level risks and benefits. But when we're talking about vaccines, the risks and benefits are both individual and community level. So here we see what's happening when everyone is blue, everyone is vaccinated, and it is protecting the vulnerable people who are signaled by yellow. So the idea with these kinds of displays are that what we are attempting to do is to take these relatively complex mathematical models that are built with partial differential equations on the back end. Next slide, please. And turn it into something that is more accessible. So this is an adaptation that we made early in the pandemic to show how social distancing or physical distancing works to prevent transmission of COVID-19. So this is one of the ways that we took this and quickly adapted it, and we are working on additional ways of using these kinds of methods to help people understand the science behind why certain strategies are suggested by public health, and we hope to be able to use these to help people better understand the COVID-19 vaccines once those vaccines are available. Thanks so much.
Great, thanks so much, Holly. That was fantastic as well. Okay, so now we're going to have a few questions that we've got prepared for each of our speakers. First question to Shannon. So what should we be doing now to ensure best distribution of or access to a potential COVID-19 vaccine when one is approved?
Thanks, Jeff. And actually, coincidentally, there is a question that was sent to us very similar to that. So maybe I'll go ahead and read that question as well, and then I'll answer them
Sure.
together.
Yeah.
So the question is posed, what types of activities can we as public health nurses and advocates do to try and improve access for people who want access to vaccines, but may have structural or systemic barriers to getting them? So it's obviously a question on people's minds, what we can do. So I think, we have a bit of time before the vaccine is available. We can do a bit of preparation to think about how we should do this. And the key is really going to be thinking strategically about who is currently underserved by vaccine programs. And if we wanted to look at a model that is, probably more similar to COVID vaccine programs, we could look at something like the influenza vaccine. So something where you're trying to reach a wide age range and diverse population. So if we look at, what's worked well for influenza vaccine in terms of increasing uptake, things like increasing the number and type of providers that can provide vaccines. So many provinces have moved from either solely physician delivery or solely public health delivery to now including pharmacists in the delivery strategy. Increasing the locations that vaccines can be provided. So, you walk into your local superstore during the flu season and there's a pharmacist sitting at the front door offering vaccines. They're in the shopping malls and things like that. So those strategies, I think, could certainly work. Even with those in place, though, that we know there's populations that don't get influenza vaccines. So obviously there's issues around confidence and complacency and those others, but just focusing on the constraints piece, things like transportation to the clinic or physical disability, people who have less frequent interactions with the healthcare system or who have had negative interactions with the healthcare system, people in socioeconomically deprived areas, people living alone who can't access the service. So I think we need to be thinking about those populations as we are preparing for these COVID vaccines that are arriving, and thinking of strategies where we can target those populations. And my newest mantra has really been take the vaccines to where the people are. And it's sort of consistent with what Holly was saying about don't design things for the way you wish people were. And the same idea is don't put vaccines where you want people to come, whether it's convenient for them or not. Take the vaccines to where they are. There's obviously operational issues around that, but that I think should be our driving mantra.
Okay, thanks, Shannon. Next question for Devon is, how can clinicians effectively counter the misinformation that patients read online?
Thanks for that question, Jeff. I think this is a question on a lot of clinicians' mind, and the clinicians are often dealing with a lot of misinformation among patients and often in pediatrics, but not just in pediatrics. And all of this can be overwhelming because clinicians have a lot of responsibilities and don't necessarily have a lot of time to be searching and fact checking every little thing. However, as COVID has brought to sort of the forefront of attention, disinformation is a public health threat. And while it's not reasonable to expect every clinician to keep up with every new myth that crops up among their patient population, there are some things that clinicians can do to fight disinformation. So one of the things is by enacting proactive and responsive strategies within their individual, within their clinical, professional, and public spheres at all these levels. There are different ways that clinicians can play an important role in combating health disinformation that has the potential to cause harm to individuals and communities. So clinicians, sometimes through their practices, departments, or associations, can monitor for disinformation trends in their areas. And when a patient comes to you with misinformation, you can use the same techniques that I described before to correct misinformation among acquaintances, appealing to shared values, referring to an authoritative source, correcting the error without sort of reinforcing it. If they're bringing you something that is connected with a known disinformation campaign, you can also let them know this. Some people out there are trying to sell you on this because of X, Y, Z, because it meets their agenda that's unrelated, or because it's going to make them money. People don't like, being taken advantage of. So you can let them know if that's the case with some of the things they're bringing to you. Also, clinicians and clinical associations should also consider speaking out publicly to address misinformation that you're encountering a lot in your region or in your institution, especially, again, if it's part of an identified disinformation campaign. So things like op-eds in regional papers and doing media interviews on the subject are helpful ways to get the word out in your area if there's someone that's trying to scam or mislead your patients.
Great. I'm just going to interject one of the questions from our audience, which is very related to what you just said. This is from Hina Hakim, who was just mentioned in Holly Whitteman's talk. Usually disinformation is played on emotions. So what are the best practices to handle disinformation in such cases, where we're talking about emotions?
This is a really good question. And honestly, in my mind, this dovetails with another question I saw pop up in the Q&A about the backfire effect. So maybe I'm going to bring those together because the answer to both has a lot to do with the evolution of the field of vaccine communication and how we answer that. So we used to be looking really for sort of the silver bullet, the way to communicate about vaccination to people that's going to work for everyone, basically. And we saw a lot of backfiring to that. And some of those backfiring studies have not been replicated or haven't held up well when we've brought them to specific communities. And so the field has really come forward a lot looking at the importance of context and knowing the population that you're trying to communicate with and communicating in ways that work for them. So the way this brings in emotion is some studies have said, oh, well, let's use emotional, anti-vaccine discourses often use emotional things, scary pictures of sick children, et cetera. Maybe we should do that on the pro-vaccine side. And then it's been tried, has sometimes backfired. However, the role of emotion is very important to a lot of people. And different populations weigh differently, whether they will respond to sort of a more narrative emotional story or a more statistical, sort of scientific, if you will, story. So to some extent, if you're a clinician, think about the person, the patient, and this is much easier, of course, for people in longitudinal care relationships where they do know a patient or family. Think about how they like to communicate and how they seem to value communication and communicate in ways that works for them. If you don't know someone, often pulling a little bit on both, maybe a narrative and as also some numbers for someone to offer both ways of decision-making can be helpful. Do you feel like that addresses that question, Jeff?
Yeah, thank you. Thank you, Devon. There are more questions for you, Devon, but maybe I'm just going to hold them for now. And why don't we go to Holly for a bit and just to give you a little bit of a break. Holly, for decision-making interventions, how can we deliver these to people with low literacy and or language barriers?
Thanks. Yeah, that's a great question. So this is a big issue in health education and health communication more broadly. What I will say is that in the decision-making space, this is something to which people are increasingly paying attention. There has long been sort of a practice of aiming for approximately a fifth or sixth grade reading level. What I will say is that there has been some work looking at presenting relatively complex topics in plain language that has shown that presenting in plain language works well for everyone. And I always think of times when, so in a previous, many years ago, I helped run a science and engineering camp for young children. And it became very clear to me that in order to if you really understand something, you will be able to explain it relatively simply. And so if you really understand something, you should be able to explain it in a simple way in order to be able to communicate it to people who have varying levels of educational background. Most people are able to understand these concepts, but concepts are not always presented to people in a way that makes it easy for them to understand. So it is really about finding ways to make sure that, that what you're presenting is understandable to people. And one of the best ways to do that is to iteratively user test it with people who have varying levels of background knowledge and background education with respect to different languages. So we, being in Quebec City, we work very much in both English and French. And then whenever we can, whenever we have the budget for it, we also add captions in other languages. I do think that as tools become more modular, it will get easier and easier, especially when decision support tools are available online. It is getting easier and easier to provide things in other languages. Cultural adaptation takes a little bit more work than just translation, but that is also an important aspect of this because it isn't always just about the language. It can be about culturally adapting the way we talk about health risks. The way even we talk about health can be different from one cultural community to another. So just being attentive to that issue and seeking to engage and to work collaboratively with people from different groups and different communities is an important approach to attempt to meet everyone's needs and ensure that the things that we develop are useful to everyone and not just people who are relatively highly literate.
Thanks, Holly. That's really helpful. Another question from the audience is, how can community organizations, this is to any of the three of you, how can community organizations and philanthropic foundations work with clinicians or public health to promote scientific information or advocacy or dispel misinformation? So it's like, yeah, I don't know if Devon, you want to give it a first stab, or any of Holly or Shannon?
Well, one thing that I know has seemed quite promising is community-based approaches to conversation and dialogue. And I understand that there's actually a Canadian effort going on right now associated with COVID-19 resources.ca, which I have no affiliation, but to host roundtables, community gatherings right now. Online in most cases, although not necessarily in all situations, to give communities a chance to have conversations with medical experts or scientists so they can ask questions. I read this, is it true? What about this aspect of COVID? I'm worried about this, should I be worried about it? That kind of community relationship and trust building is a really fantastic idea, I think, especially with communities who may not have a lot of underlying trust with medicine because of historical marginalization and wrongs that the government or the health system has done to their community. Offering up a chance to ask their own questions about their own priorities to experts is a great way to sort of share accurate information, correct misinformation, and also build trust.
Okay. And these are pretty tough questions. Can you speak more to these strategies and how to use them with a trauma-informed lens appropriate for working with Indigenous populations? This is getting specific. Anyone want to give a stab at that one?
I could share a couple of comments based on some work our team has been doing with some Indigenous communities, First Nations and Métis communities in Alberta. And I mean, really the issue is you need partners, right? You need the community to be a partner in developing in the message. It's the same as if you're doing research with a community, they need to be involved in it. So I think, you know, those of us that don't have experiential knowledge with what that population has gone through should not be designing strategies and communication for that population. That knowledge needs to come from the community. So I think it just speaks to the need for partnership between those communities and populations and the communications experts, where we can draw the best of the communication science and combine the best of the experiential knowledge of what that population has for preferred communication strategies.
Great, thanks, Shannon. And here's another tough question. Where did it go? Okay, I'll ask another one. Oh yeah, here. You know, as Dr. Greyson noted, vaccine hesitancy, particularly related to COVID, has become highly politicized. Given this, shouldn't public health policies explicitly address underlying political issues? After all, perceptions of risk, acceptability, responsibility, etc., are all filtered through cognitive and cultural biases, which are, of course, in part political. Anyone have a response to that question?
I can start with this, but Holly, I think you were nodding too, so feel free to jump in. I mean, there are a lot of different meanings of the word political. So I think I would caution public health entities from associating with sort of big P political, like parties, specific, you know, politicians, this type of thing. Public health is for everybody. And the more that we can make everybody feel a part of public health, the better that our health outcomes are going to be. So in terms of being political, I caution against it when it comes to sort of, oh, this politician's platform is going to be better on the COVID response than this politician. I would be very careful with that when, you know, in an official public health capacity. That said, of course, many of these issues are highly politicized, and it is important to understand the way, again, in specific community contexts, things like pro-social values are understood. So some communities view their responsibility for the whole community to be everyone in the country, or everyone in the province, or everyone in the world. And some communities view their responsibility to be more to their immediate family, or perhaps to their religious group, their congregation, or their neighborhood. So understanding those kinds of values, which again, I would call sort of little p politics, not big P politics, understanding those and being able to speak those languages in ways that resonate with those sometimes politicized values of specific communities is important. I know someone else wants to jump in there too.
Okay, thank you, Devon. Anyone else? Or we can move on to the next question. If anyone wants to jump in, you're welcome to. Holly, no? Okay, so next question. As a vaccine advocate and a polio survivor, I want to help combat vaccine hesitancy. How can I help my community see the importance of vaccines?
I think any of us could speak to that.
Yeah, we can all speak.
But to fill the gap, the uncomfortable gap of silence. I mean, I personally am a huge believer in influencing the people you can influence. So in your social sphere, in your professional sphere, and I'm also a big fan of role modeling. So if people are okay getting up and telling their friends why they don't trust vaccines, the rest of us should be comfortable getting up and telling people, you know, oh yeah, sorry, I have to run. I'm heading off to get the flu vaccine because I want to make sure my kids are protected before they head to school. So just, you know, making it blatantly obvious to people around you that you trust the vaccine process and the people who are making those recommendations, I think can be like just the most obvious start. You don't have to be an expert. You don't need to be able to refute every meme that you see on Facebook, but just sharing your own trust in the system can be really powerful.
If I can add to that, I think we know that narratives, stories, individual stories are really powerful. They hold a lot of power. And for that reason, sometimes in decision-making research, we're very cautious about using stories because they do wield a lot of power. And it's not always clear how that power is, to what extent is it influencing people in a way that might not be fair. In your personal life, it's a completely valid thing to share your story with people you know, and also to the extent that any one individual is comfortable sharing their story, I think that can be a really helpful thing. I have shared, my husband grew up on a commune and was not vaccinated as a child and felt quite strongly that our children should be vaccinated because he had measles and he didn't like it. So, I think that these kinds of stories, when shared with the permission of the person, are, as Shannon said, really important to have out there, because they are part of the reality in which we all live.
Yeah, I'll just add on to that a bit. There's two elements of sort of sharing stories as a communication technique that are very persuasive. And one is the narrative manner that they're told in. And the other is the way that a person may feel personally connected or closer to an issue or a threat, because they know someone. So people who know someone who has had a very severe case of COVID-19 are more likely to take seriously protective measures. People who know someone who had polio are more likely to take seriously polio vaccination. So I think there is, whether it's for clinicians to say, I know, varicella vaccine, chickenpox seems not scary, but I have to tell you, we had this one case at this hospital once, and there were these really scary things that happened to that baby, and I don't want to see it happen to someone else in my care. That kind of personal story is very effective, as well as sort of for a non-clinician, just in your communities or in your local newspaper or in your school community, that type of helping people feel closer to these, polio, a lot of people in Canada don't feel very close to anymore, which is wonderful. But also, we can get a little complacent, to go back to the 5 C's about it. So it's both the narrative way a story is told and also the closeness it can bring to a topic.
Thanks. That's great. Next question for Holly. What are your thoughts on the application of counseling techniques like motivational interviewing to people experiencing vaccine hesitancy?
I think motivational interviewing is a really excellent technique to use. And I think, so I tend to work in the shared decision-making space, and there's a lot of overlap and a little bit of tension between motivational interviewing and shared decision-making in this area. So motivational interviewing is very much a technique of meeting people where they are, connecting on the basis of their values, and attempting to move them towards a desired goal. The distinction between that and shared decision-making is shared decision-making does not have a particular desired option that people will choose. And so that's where some of this tension comes in the vaccine space. But there's been some really excellent work. So Arnaud Gagnard, who is I think he's a pediatrician, at Université de Sherbrooke in Quebec, has done some really interesting work in which new people who had just given birth, so just had a newborn, were approached by someone to engage them in a motivational interviewing method about routine childhood immunizations. And it did seem to be an effective way to help ensure that those newborns did eventually have their routine childhood vaccines. So, I mean, and I think this goes back to what Devon was talking about, is connecting with people as humans and connecting on the basis of what matters to you and what are your values, is a really important way to have these conversations, about these issues. And there's a lot of power in that kind of human to human connection.
Great, thanks, Holly. Okay, here's one more question, and we'll see how many more we can get in here. So the baseline assumption here is that there is a safe vaccine. And specific to COVID-19, given that it's very embedded in health community to push back against vaccine hesitancy in an almost automatic manner, do you think there is actually a space within the medical community to address legitimate patient concerns of safety? And what do you think clinicians can do to keep their own vaccine response habits or biases in check? Anyone want to?
I'll take that one.
Sure, Holly.
So yeah, I think that speaks to what I was just talking about the tension between motivational interviewing, which is coming in with this, we want you to get vaccinated, versus the shared decision-making approach, which is, this is your decision to make, and we're going to help you and support you with this decision. I do think, Shannon showed the headlines. I actually have a lot of trouble with the fact that people are even being asked about whether or not they would accept a hypothetical vaccine. They haven't even, and we talked about this in the preparation for this webinar, and I think we're all on the same page, that it's not useful to ask people that question right now. And I do think it will be very important. This speaks to the issue of transparency. It will be very important to be really transparent about, this is what we know about the risks and the potential harms and potential benefits of this vaccine that has been approved. Here is the process that it went through. Here are all the safety checks that it had. Here is what we know. We're very confident in this. Here are the limits of our knowledge. And to understand that, different people are going to have different reactions to that. I think that is going to, this is really going to test public health in Canada.
Mm-hmm. Mm-hmm. Anyone else want to jump in on that?
Oh, sorry.
Go, Shannon.
No, I was just going to add that there's nothing more damaging when you're talking to somebody who has concerns about a vaccine than, that sort of automated, vaccines are safe and effective. What are you talking about? It absolutely, it shuts down the conversation. You lose trust because it's not true that vaccines are 100% safe and effective. I think we need to be realistic and honest about those things, because trust is what underlies all of these decisions. And we lose trust the minute we pretend that vaccines are 100% safe and effective.
And I was going to bring it back to the recommendation of transparency, which is so key. Both transparency for, if there are approvals, what are the data on which those approvals were, approved by Health Canada? What are the decisions that the provinces are making about prioritizing which groups get to get the vaccine first and why? What is the rationale behind that? I think that is critical for building public trust. In addition, what are our ongoing safety and vaccine monitoring mechanisms? I'm a social scientist by training. I don't have a clinical background. Before I spent 3 years embedded in a vaccine research center at BC Children's Hospital, I had no idea how much vaccine safety and effectiveness monitoring was going on. And now that I've seen it, I understand why vaccine scientists can get a little offended when they're, accused of not worrying about the safety, or other people people who are vaccine hesitant will say they're pro-vaccine safety, and vaccine researchers will say, but I'm pro-vaccine safety, that's my whole job. And I think it's not that, anybody is anti-vaccine safety, but it's not obvious to the public what is going on behind the closed doors in public health and in hospital research centers and the like. So I think increased transparency can really help with the trust. And as Shannon, you were just saying, improving our discourse. It's true that public health has historically sort of relied on vaccines are safe and effective means something when you're talking about the whole population that is different than you're talking about your one self or your one baby. And so understanding that, using messaging that people are going to really understand and trust is so key.
Yeah, thanks. I am going to squeeze in one more question for Devon. So I can't keep up with fact checking everything. How do I know if something is true or not?
This is hard, right? Because of course I'm going to say before you share information, it's important to fact check it, because none of us are immune to misinformation, and it's particularly easy to be duped by content that appeals to our confirmation bias, our natural inclination to read, remember, and accept information that reinforces our existing beliefs. But sometimes you can't fact check everything. In that case, it's important to accept that you're not going to be the first person to know it, whatever it is, and to refrain from sharing that until it's verified. So one strategy that many people find useful to help filter the tsunami of COVID information is to subscribe to some sort of daily or weekly update from a reputable source, such as a government agency or mainstream news publication, or to follow, if you're on social media, follow a few reliable experts, health journalists with a long record of reporting on pandemics on social media, say Twitter or Facebook, and refer to their updates. If you do want to fact check something, and I know this wasn't your question, but there are some helpful Canadian and international websites, including the aforementioned COVID-19 resources.ca, UK-based fullfact.org, US-based factcheck.org, and some international efforts such as the AFP Fact Check. But also something we all have to do, scientists, public health people, general public, is accept that uncertainty, while uncomfortable, is normal right now. This is a very new disease. And anyone who doesn't express a degree of uncertainty in scientific findings less than a year after we identified this completely new virus should probably be viewed with a little bit of suspicion. So if something seems too good to be true, definitely hold off on that until you've been able to fact check it.
Great, thanks so much, Devon. So it is now at the 1 hour mark, so I think we're going to have to end this webinar. Thank you so much to our three speakers for your excellent presentations and discussion today. For those, thank you to the audience for attending, and thanks for your great questions. We are going to take the questions that haven't been answered during this offline, and we're going to try to answer them afterwards, and you can feel free to send further questions. I would encourage all of you to follow Holly, Devon, and Shannon on Twitter. I know Holly is a very prolific tweeter. At least I'm not so sure about Shannon and Devon, but I know Holly tweets a lot. I think Shannon as well. I've seen her on my feed as well. So thanks to everyone. Until the next webinar, I hope you all stay safe. Okay, take care. Bye now.